Okay, we'll get started. Thanks everybody for coming this morning. If you're like me, it wasn't so easy to get up and get moving, but here we are, and I'm glad to see you. So the topic that I was asked to speak about was, is there a place, an important place for leadership-oriented doctoral programs in the future of our educational agenda? I adjusted the title a little bit to pose the question as to whether such programs should be expanded, because they already do exist. And I'm going to talk a little bit about a bit of the background, the history of what they are and where they come from. And then I want to share with you a little bit of our experience at Harvard Chan School of Public Health, creating a Doctor of Public Health degree, which was very much explicitly intended to be a leadership-oriented doctoral program. And then I want to share with you some of both the positive and some of the challenges that we faced, and some thoughts about things that those interested in developing such programs should take care to consider going forward in the future based on that experience. So starting off, just to unpack, what do we mean by doctoral programs, okay? And I think we need to understand a bit of the history. And it's actually kind of interesting. Reiner, in one of his many efforts to educate me, did share with me the very interesting history, academic history in Germany, which really underpins much of the academic structures that we find today in Western universities around science and publication and so on. This model really emerged to a significant degree from German and UK universities in the 19th century. So doctoral programs were traditionally defined through traditional academic disciplines, which we mainly find today in faculties of arts and sciences. So things like biology, literature, philosophy, history, these were the traditional academic disciplines in in universities, both arts and sciences. But what we've observed around the world, which I think has been very significant, is the development of new, what we might call professional academic fields. Things like engineering, medicine, in fact, is one of these fields, business, and public health. These are fields that are now embodied in specific institutions like schools of public health, and whose existence really was to create practitioners in different professional fields. But these institutions were established in universities, so they came up against the tradition in universities of being much more research-oriented rather than professional practice-oriented. And we see today that many of these institutions really are still very much research-oriented. But these professional fields are characterized by being interdisciplinary or multidisciplinary. And this has created a challenge because the traditional academic fields are the means for assessing the quality of work that's been done. But when you create multidisciplinarity, where does the standard come from for assessing quality and excellence? We've seen that these professional education programs are growing dramatically. They already comprise probably more of the university than many of the traditional academic fields. We even see new fields emerging in areas like the sciences, like neuroscience and so on, which are multidisciplinary. And many of these professional schools focused on master's level education, preparing graduates for work in professional practice. But now there's an increasing emergence of more advanced professional training, awarding a doctoral degree. Doctor of Business Administration, Doctor of Engineering, Doctor of Science. And this is reflecting, I think, a perceived need that master's level training, often only 1 year or at the most 2 years of training beyond an undergraduate degree, may not provide sufficient depth and richness in a world where things are becoming more complex, technically complex, and additional training may be needed. So should there be something distinct about a professional doctorate? What's the difference between a professional doctorate and your traditional idea of the doctorate, the PhD. So the PhD is basically characterized by the idea of advanced research training, creating original scientific knowledge, and evaluated by a jury of peers, themselves PhDs. So when you're writing your PhD dissertation and you're being examined by other people with PhDs who determine that your work meets a quality standard of creating original scientific knowledge. And that's the basis on which you're awarded a PhD. And we also like our PhDs to have the competencies to carry forward future original research. This is one of the criteria for assessing them, as well as teaching others to do the same thing, teaching others to do original research. For some professional doctorates, and I put some in quotes because we see that there's actually a range of experiences, these advanced research competencies have been less emphasized and have been substituted by competencies more related to professional practice and leadership. So this is what I think characterizes the idea of a professional doctorate. It's not that it is not a research-oriented degree. It can be, but there's a substitution of some of the advanced training around research knowledge and skills for other knowledge and skills. And this has created some difficulties in our discourse in universities about these degrees. Some people describe them as not being academic. They're practical but not academic, or they're not research-oriented. Therefore, they're not somehow as good as or as meritorious as the traditional PhD. And I don't agree with this view at all. And as in my work, especially in developing the DRPH program at Harvard, we tried very much to not go down that road of thinking. But it does raise an important question that professional doctoral degrees have to answer, which is, what is the standard that they are trying to achieve? What criteria should be applied in creating and awarding these degrees? What's the basis for those criteria? We need to answer those questions to have professional doctoral degrees that are both excellent and also perceived as being excellent in their own regard. So a little bit about the Doctor of Public Health degree, because that is the current major form of a professional leadership doctorate in public health. We go back to the early 20th century with the creation of the academic field of public health. The well-known reports by Welch and Rose and Rosenow formulated public health as a distinct field of professional study. And this happened more or less concurrently with the reforms in North America that were taking place around medical education, the Flexner Report, and academic medical education. Now, in the United States, we really were leading in the world in the formation of professional schools of public health. That's become more widespread now, but traditionally, public health was practiced as community or social medicine in the context of medical universities and medical education. And I think that was the history here in Heidelberg as well. In 1966, a very path-breaking article by Romer titled "The Need for Professional Doctors of Public Health" noted, and I'll read this, "The need is for specialists in the health of populations prepared to at least the same level of professional competence as physicians dealing with the sickness of individual patients. The need is for personnel to plan, organize, and operate," and I emphasize operate, "healthcare systems the need has become greater and more complex." And this is certainly true today, much more than in 1966, and certainly true around the world, when many nations that in 1966 were just beginning to form their national health systems now have large and complex national health systems. Many have repeated this call and repeated it in various forms in the literature since that time. We see one of the responses is the creation of DRPH, Doctor of Public Health degrees, and conceptually emphasizing public health leadership. But these programs are still struggling with whether and how much to substitute some of the traditional research competencies of the PhD with practice and leadership competencies of a public health doctorate. And we still find DRPH programs that look, feel, smell like PhD programs, and then we find some that have differentiated them quite distinctly. Now, I want to spend a minute talking about our experience creating the Harvard Doctor of Public Health degree and building on this framework, which expresses some effort to find some of this balance. But let me just share a little bit of some of the background at Harvard. Harvard was simultaneously awarding a Doctor of Public Health degree and a Doctor of Science degree, not a PhD. PhDs were awarded in a couple of fields at Harvard School of Public Health, those fields which had a parallel or a partner academic department in the Faculty of Arts and Sciences. So, for example, you could get a PhD at Harvard School of Public Health in biostatistics because statistics existed in the mathematics department at the Harvard, at the Arts and Sciences side of Harvard. But you could not get a PhD in global health or international health at Harvard School of Public Health at that time. And the original history of this was that people with a medical professional background, doctors and nurses, they did the Doctor of Public Health degree. People with a non-medical, non-clinical background, they did the Doctor of Science degree. But if you were to look at the picture in the 1990s or early 2000s, there was no difference between these two degrees. The requirements were the same. They were both research degrees, and they both produced a research-based dissertation as a culminating experience. So in undertaking the development of the Harvard DRPH, we really thought carefully, how do we create the difference between a professional doctoral degree and a research-based doctoral degree? And how do we formulate that substitution of the professional-oriented skills with some of the research-oriented skills? And this diagram really lays that out. And without going into too much of the detail here, you can read more about this in the article that's cited below there. It's important to note that we began with the notion that there are critical elements of what we call foundational knowledge that all doctoral students should master. And they included methods and theories and concepts. So this is not to say that this degree does not contain advanced training in methods like statistical analysis, epidemiology, and so on, and theories around health change, behavior change, and so on. Interestingly, at Harvard, the DRPH degree is the only doctoral degree to require both quantitative and qualitative methods training. The PhD degree offers qualitative methods training, but not as a requirement. So this was something we recognized as important, that a professional leader in practice should understand the importance of both quantitative and qualitative data. We then added a component around enabling change, and there's space for training around competencies in management, communication, leadership itself, and bringing about change more broadly. And then we worked on the question of what should be the culminating experience of this degree. What distinguishes the DRPH thesis from a PhD dissertation, right? And this led to the development of a fairly detailed manual about what this could contain, and also explicit criteria for its evaluation. Now, one important thing to note is that in thinking about the criteria for the evaluation, we came back to the same criteria that are used in the PhD degree. That is peer review. Your work should be reviewed by a committee of peers as to whether it satisfies the written criteria around leadership and applied knowledge building on your DRPH training. And I want to emphasize that it was very important to not create a firewall between professional training at an advanced level and research training. Professional training could include research. And there is research on implementation, there is research on policy. But it didn't have to include research in the traditional sense of research, okay? And, we do have new fields like implementation science and so on, which provide a kind of a border across traditional fields of research and new topics and techniques that are being used. So I won't go into any more detail about this, but it was an interesting process to try to give some shape to this. And it was an interesting process to do this at a very highly regarded, research-oriented university, where faculty members have been recruited for decades for their research excellence and have spent most of their energy in educating their students to achieve similar research excellence. So we had a big challenge working with a very diverse faculty to create the conversation of understanding and respect of what this professional doctoral degree would include. So I want to end up by sharing some lessons that I think we learned in this process, and they may be helpful for thinking about how to expand efforts like this at other institutions. First, one should assert that professional education is academic education. This is not a different kind of education, and this is important in the discourse in research-oriented universities. We need to develop and strengthen the means to achieve competencies in professional skills like leadership and communication. And this was a challenge in our school because we didn't have necessarily the faculty and the courses to teach these subjects very effectively. We wanted to borrow initially from Harvard School of Public Policy, the Kennedy School of Government, but they were kind of full up, they weren't so open to accepting 10 or 15 students from the School of Public Health to take these courses. And this capacity needs to be created, invested in, and funded. We think it was important to maintain space for both practice and professional research in a professional degree. It can be a research degree, but it doesn't have to be a research degree in the traditional sense. And this means we need to have space for the other dimensions in the culminating experience, like leadership, management, policy, and we need to define what those mean exactly as best we can and develop and rely on explicit standards of peer review to determine whether completion of the degree has been satisfied. And lastly, and I think importantly, we need to review, revise, and learn from the experience of current and former students. And I have to say, this is one area where, in our experience at Harvard, we didn't fully do what needed to be done. There are probably today between 50 and 100 examples of DRPH theses that have been completed, but a systematic review of these, what they contain, the criteria that were used to assess them, and so on, this still needs to be done, and we need to learn and revise from our experience. So, to conclude, should these leadership-oriented doctoral programs be expanded? I'm a believer, yes. And I think especially COVID-19 and new challenges like climate change and the increased global intersections have shown us that traditional preparation of public health experts in the PhD degree does not often sufficiently prepare them for the leadership roles that they are being asked to undertake. And we need to create more of this cadre of leaders and practitioners with specific competencies that go beyond traditional research training in public health, and also go beyond what people typically get out of an MPH degree, which in some cases is a year or 2 years of training, good training, important training, but not advanced enough for the complex world that we hope leaders are going to take the place in leading. So, and I also want to conclude just by saying that I think that creating the space for these programs is especially important in lower and middle income countries because they are facing very urgent practical problems of health improvement and health systems development for which the advanced research competencies are important, but not exclusively what is needed. So we need to balance this, and to the degree that universities that are growing in low and middle income countries mimic only the research-oriented emphasis of universities in the global north, I think they will not be fully delivering what is needed by their societies and populations going forward. So I would argue that, in fact, DRPH degrees are even more important in low and middle income countries than they might be in the high income countries. Thank you.
So you see the next one?
Yeah.
Okay, so to begin, here's a child who is severely dehydrated from diarrhea disease, which is very common and here's another child who is severely dehydrated. You can see the fontanelle, the soft spot on the head, is depressed. Now, when I came to Bangladesh, which was then East Pakistan in 1967, it was estimated that almost 30% of all the deaths in children in the world were due to diarrheal disease, or about 4 million. Today, that number would be about 12 million, or 10 million, given the population growth. So that's how severe the problem was. And in the summertime, you would see beds after beds such as this, with children with dehydration from diarrhea, and the bottles would be intravenous fluid that was given to these children. Unfortunately, this fluid was not available in the rural parts of Bangladesh, and so you had mothers coming in with their children by country boat, which would often take hours, and they would delay coming in. And so when the child reached the treatment center, either there would be no doctor, no intravenous fluid, or the child would be severely dehydrated. Here is a woman coming in who had cholera, the most severe of all the diarrheas, in by the village ambulance. And here's an individual who, you can see how old this picture is. It's called the Pakistan Seco Cholera was the research laboratory. Bangladesh, of course, is now Bangladesh, not Pakistan, and neither is part of the Southeast Asia Treaty Organization. Here's a gentleman that required about 90 to 100 liters of IV fluid, which would have been the equivalent of 4 months of his salary, but he would not have had access to it in the rural areas. So diarrhea treatment had to be inexpensive, easy to use, deliverable by non-professionals because there was only one doctor for every 50,000 people in the rural areas, physiologically sound, effective, and acceptable. And after a number of physiologic studies and gut flow studies and so on, an ORS solution was developed and eventually recommended by WHO. And you can see it included sodium chloride, sodium bicarbonate, potassium chloride, which is found in coconut water and other fruits and vegetables, and glucose. Glucose was the magic ingredient that allowed these other elements to cross the barrier into the circulation and allow for the children to be hydrated with this solution. Here's a child who's severely dehydrated. You can see again that look that she has, almost apathetic look. And here is her mother actually treating her with an oral solution. And here she is, a few hours later, completely recovered from the dehydration. She continues to have the diarrhea, but the dehydration has diminished, and she can now eat and is alert. This is the basic principle. You go on holiday, your plant is deprived of water. You come back, and hopefully, if the plant has survived, you can revive it. That's the basic principle behind this. Now, the challenge then became, how do you take this fluid, this sodium chloride, sodium bicarbonate, potassium chloride, and glucose, and get it out to people in the community where they are. Not where the doctors are, but where they are. So one thought was to put this, these salts and sugar into a packet. However, any final solution is not only the ingredients in the package, but the amount of water in which it's dissolved. And here's a picture from Guatemala, and you can see there was no standard container there or in Bangladesh. Is it the Pepsi bottle, the whiskey bottle, the canteen? Which is the proper amount? And this solution is made up for 500 cc, or excuse me, for 1 liter. So there was no standard container. Now you can provide people with a standard container, as you can see in this picture, and a standard packet, but producing the container would cost a lot of money, and you would still have to distribute it to people in the community. Working in his home kitchen, actually, the CEO and the director and the founder of BRAC, which is now the world's largest NGO and the #1 ranked NGO, developed a method which used a pinch of salt and a scoop of sugar. In this case, it's refined sugar, but in the villages, it would be a crude sugar called gur, and putting that in a half a liter. But you still have to develop a half a liter container. So what was done is that they developed a cadre of young women who would go house to house in the community and teach mothers how to prepare the solution. And you can see that the worker in green side, has a container in her hand, which is a 500 cc container. She asked the mother then to produce a pan from her house, in this case that white pan. She pours the contents of water from her container into the mother's container, scratches a line, and now the mother has a 500 cc container. And with that 500 cc container, she can also prepare in her home the oral solution using a pinch of salt and a scoop of sugar. Now you can see that teaching her in her home is really advantageous because you have the child sleeping there, you don't have the chaos of a outpatient department which would be present in any health center. It was later developed that they could teach not just one woman in her home, but here 4 women being taught with a flip chart. And what you also notice in this is all the children standing around listening. And of course, children are much better at picking up messages than adults are, although today these children would of course all be in school. So what did the BRAC Oral Therapy Extension Program demonstrate? Well, first of all, over a 10-year period, 12 million mothers were taught in their home to prepare the ORS, the oral rehydration solution. Knowledge was transmitted to the mothers in the community by a female worker whose salary was based on what the mothers learned. So if the mothers learned, the worker was paid more than if she did not learn. And there was only 7 basic ideas that were combined with active demonstration. Knowledge has persisted in this community, even though mothers were only taught at one point, children born after their mothers were taught, about 85–90% know how to prepare the solution and what it's for. And Bangladesh today has the highest use rate of ORS in the world. Now, just as an extension of this, to show you that this is brought forward now almost 50 years. In 2009, there was flooding in Dhaka, and in the 9-week period, from July to August, there were greater than 42,000 cholera patients admitted to the ICDDRB, which is the old cholera lab, and no deaths reported from dehydration. ORT was extensively used with family members participating in patient care. And here you can see the extent of the flooding that took place. People were using water. Here are garment workers going to their work in the flooded streets, and people trying to get clean water from pumps, which was not possible, and therefore cholera had developed. People were brought into the hospital and rehydrated if they were in shock, and large quantities of oral solution, in this case rice-based solution, were prepared And here are patients in the hospital using the ORS solution. They were seeing up to 1,000 admissions a day. And the key was that family members participated in the care of their other family members. No one comes to the hospital without a family member accompanying them. And as people knew how to deliver the oral solution, they did here in the hospital, and it was highly successful. So what does all of this teach us? Well, the lessons from the ORT that are relevant to teaching global health. First of all, cases such as these are an excellent teaching tool for addressing global health issues. Field-related experiences need to reinforce these cases. Cases are most effective if they deal with local issues, but regional approaches can be useful. So, for example, in climate change issues, in flooding and so on, these are clearly regional issues, as was the present pandemic. Cases should focus on assessment, cause, and mitigation, and address solvable problems. Solvable problems. Because unless problems are solvable to the students, they lose interest. You need to have a multi and an interdisciplinary approach that is critical in case development and teaching. And lastly, faculty in all of these educational institutions need to be trained in case teaching, because case teaching is its own method. As an example, here are some cases that have been developed with James P. Grant School of Public Health, which is at Grant University, with other faculty at the Hanoi School of Public Health in Vietnam. Impact of flooding in Bangladesh, especially as a risk factor for certain diseases and service delivery. Reducing the transmission of Nipah virus, which is present particularly in the western side of Bangladesh. And the impact of climate change on the transmission of malaria and other vector-borne diseases. And in another institution where I have been affiliated, at PHFI and CCDC, based in Delhi, the effect of air pollution on comorbidities. So the lessons from the ORT story are that researchers need to be embedded in areas where the problems occur. The development of ORT would not have occurred at the NIH or at Harvard because people did not see the need for it in those environments. We need to make sure that we take research to the people and learn from them to promote evidence-based interventions, as was done in this case. Thirdly, context determines research questions and how success is to be measured, so that low-cost, acceptable, attainable, and sustainable interventions are often better than high-tech solutions. So with that, let me conclude my remarks and take any questions that are present in the audience.
So I'm the chair of the session now. Richard, thank you very much. Can you hear us?
Yes, I can.
Okay. Any questions from anyone in the audience? I think Liner feels I'm not getting enough exercise.
Hi, Richard. This is Malavika.
Hello, Malavika. How are you?
Good, thank you. So, because I think 2 days back when I was flying from Dhaka to Germany, to Istanbul, Turkish Airlines, one of the Bangladeshi guy was kept vomiting. And they brought him to me because there was no doctor, and I cannot say that I'm a public health physician, but as I speak Bangla. And he was continuously throwing up, and then I asked them to bring the medicine box. There is no worries. There is like anti-diabetic, antispasmodic, everything. And so what I was doing that I kept giving him the mineral water, because that's the one bottle they have mineral water. And by the time we arrived in Istanbul airport, he was almost had a collapse. I called the air clinic. There's a doctor came, and there was no worries. So my flight was 3 hours after, and So they gave the intravenous 250 ml. So my question is, still now, even in many African countries, why is, although it's such a successful magic bullet, is not well accepted across the continent, and you can't find in most of the places?
Peter, could you repeat that question, because there's an echo, so it's hard to hear Malavika.
Okay, is it clear now?
Yes.
So my question is that ORS is such a magic bullet. You know that in Bangladesh it saved millions of children and adults' lives, but it is not well kind of like, not most of the countries, high income or low income countries of Africa, it's not available as a, you can't get it in most of the places. Why?
Well, so as I understand it, the question is, why isn't it used more in other parts of the world, and the availability of water? Well, first of all, I think that what's critical here was how people were taught. I think that sending out simply large messages to many, many people is not nearly as effective as this type of teaching that actually takes the lessons directly into the community. And I think that's what's very critical with all of changes that we're trying to bring about. That large-scale messages have a limited application in the community. That the community-based education, taking into account people's own needs and abilities, I think are very critical. And I think that's what this demonstrates.
Okay, thank you. Look, I know Reiner has a question, but I want to be democratic here. Anyone else have a question? Okay. Democratic democracy. Yeah.
Hi, this is Reiner. Richard, thank you for being with us and for mentoring me ages ago. I listened to your lectures, of course, on oral dehydration. The question that I always had in mind is about the water quality. If they put the same dirty water that made them sick into a cup, and even if they add salt and sugar, it's still dirty water. So what importance do you attach to boiling the water or taking only bottled water? That's my question.
The issue of water is very important. What we decided early on was that we should remove as many barriers as possible to allow people to use this. So we said use the best quality water we have. We did not say boil the water because they already had diarrhea. And in boiling the water, it was another activity they would have to undertake. And for many people, getting the fuel to boil the water would have been very difficult. They would have to do that. It would have taken time. They would have to let it cool. And it has another property. So what we recommended was use the best quality water that you have, because you don't get diarrhea on top of diarrhea. This is the water that they're using. I would not recommend using bottled water. If they have it, you can say it. But in the village, they're using water that is out of a pump, or hopefully, or sometimes out of a pond, but the best quality that they have. Every time you put in a new recommendation, a new procedure, you cut back on the number of individuals who were participating in this. And the key here is to give fluids back to the person so that they do not become severely dehydrated and expire from dehydration. So we did not recommend boiling water or getting it from a source that they may not have access to.
Thank you so much. Okay, thanks, Richard. We're going to take one more question.
Thank you. I'm Fikri Gray from Heidelberg Institute of Public Health, Global Health. My question, or my remarks here, there is maybe a big gap between the clinical practice and the public health practice in terms of the simple procedure. For example, providing ORS, sometimes we face a big challenge to convince physicians to use ORS instead of using IV line treatment. So this gap maybe should be addressed or communicate between the public health expert and clinicians, especially in some developing countries where they believe having this more advanced intervention is better than using ORS.
Well, I think that,
Go ahead, Richard.
that you have to tailor your intervention to the reality of the situation. If you're dealing with a village population that is, or even urban slum populations that do not have access to IV, then you must give them the best that you have, and the best that we have, ORS, is extremely effective. If you have treatment centers where people have easy access, you can use IV, but even there, oral solution is almost as effective unless somebody is in shock. So this is not a second-class type of therapy. This is absolutely spot on and almost as effective as IV, except if the individual is in shock. Sometimes we take higher tech to be better, and I don't think that that's the case. Simple is much more difficult to develop than is complex. Developing a simple solution requires us to think about all the things that we don't need, not that we do need. And therefore, I would urge that whenever possible, we should go with a simple and effective solution. The same thing is true in the COVID outbreak that we have today. There were many, many complex interventions, the vast majority of which had very little impact on the outcome of the case. But there were simple things that could be done in the home, formation of the individual, encouraging them to breathe and so on, getting things to the community, which turns out to be much more effective and far less expensive than many of the tertiary interventions that we have developed in our tertiary centers.
Okay.
I would say the same thing is true with other issues related to things related to climate change and other interventions.
Thanks, Richard. We've got one more question from Professor Reddy, who's deep in the dark recesses of the room. You won't see him, but you will hear him.
Hi, Richard. Happy to hear that you're free now. Just to answer Rainer's concern, one of the things that adding a lot of salt and sugar to water is to increase the oncotic pressure, which actually helps to break down the cell walls of the microorganisms and tends to, in a sense, partially sterilize the water. That's the principle of honey also. And therefore, your answer that trying to keep it simple may help and not necessarily result in additional infective potential. The second element is, now that we also know that lactobacillus is very important for replacing the flora and helping to control the area. And is it possible now that ORS can be supplemented as well, in addition to that with lactobacillus, which is available as powder?
Peter, I was unable to hear the question. Please possible for you to repeat. Things get muffled in the microphone, unfortunately.
Okay, did you hear the first part?
I'm sorry?
Okay, I think that Professor Reddy's question had to do, the first part had to do with the idea that the resumption of fluid itself has some molecular, if I'm using the right word, process of osmotic pressure process of cleaning the water. But the second part had to do with, you need to help me here, Srinath. lactobacillus, right? And whether lactobacillus can be added to ORT to make it more effective.
I don't think I'm capable or qualified to comment on the last. It's quite possible, but again, if we do that, that requires yet another stage and requires the production in a factory that would add this. If it does prove to be effective, of course, this could be added and should be added. But this would then require us to develop packets that would be given to people and distributed to them. The program that I pointed out was one that tried to avoid the use of a distribution system and take things directly to the people. But if lactobacillus is helpful, it could be added and should be added, of course, if it keeps the price low and provides the necessary improvement. The key here, as was pointed out, is that these children need fluids and need to be rehydrated. That is absolutely critical. And if we can get that message through, and it can be done in a way that provides an effective solution, then that is all for the good. But getting people to take on that message requires us also to get into the community to understand what people do and why they do it. And that was the genius of the BRAC program, which I think can happen in many other types of interventions that we will develop over the years. To keep it effective, simple, adaptable, affordable, that's what the goal should be for any of these interventions that we're talking about. It's not just ORT is but one example of that. Let me close by saying what a pleasure it is to be able to speak to you, to see so many old friends here, Malabika, Peter, and Reiner, and Srinath, and to express my gratitude to be able to present to you, and my deep regrets in not being able to be there in person.
Okay, thank you, Richard. Let's give Richard a round as well. And I think our next speaker is Sandra Bartek, who looks to be present.
Good morning, everyone. I hope you can hear me well. My voice is not too well, but I hope the microphone can still transport the information. So my name is Sandra Bartheit. I'm also from Heidelberg Institute of Global Health. My background is actually in informatics and my PhD in global health, so I kind of work on the intersection of digital technologies and how they can strengthen and support global health. And this is today one rather side activity that grew more prominent with Reiner's backwind. So today I'll be introducing our work on MOOCs. So what are MOOCs? Some of you may have heard of them, some of you may even have taken one. So MOOC stands for Massive Open Online Course. Massive in that sense means it's available to the whole world. So essentially everybody can take it, so in that way it's massive, it's available online. It's open, so it's accessible to everybody. Anyone can take it, so it's a course. So this is the MOOC, so just that we are on the same level of terminology. And what does this have to do actually with climate change and health? So MOOCs can be a key driver of global capacity building on the one hand. They can also be in that sense empowering, right? Because they are accessible. to everyone, and in that sense empowering, because it brings education to everyone in the world without having to pay money for it. So in that sense, MOOCs can be empowering and also create awareness, like looking at climate change and health, bringing that knowledge to everyone in the world. Can essentially also translate into awareness about this topic that can be also transported into communities, for example. We have seen in the past that MOOCs are actually a great tool for global education. So this is an example of one of the first MOOCs that ever was held. So this is many, many years ago, when internet was still a bit more expensive than it is now. It's an introduction to artificial intelligence. Overall, they had amazingly 23,000 students, of which 253 got perfect scores. Here you can see kind of this global community coming in, this making education available to everyone, because 410 online students outperformed the top Stanford student. So these are students coming from all places of the world, and MOOCs making available to these communities also this kind of education and giving them the opportunity to also participate. Another side effect that was noted is, for example, that there was a lot of engagement, even online, so students were teaching each other. And also this engagement from the community to translate this course into other languages, to make it available to all people who may not be understanding English very well. So overall it was translated into 44 languages. So this was one of the first MOOCs, and since then there has been a very steep trajectory in the realm of MOOCs. So here you can see one of the most popular MOOC platforms. It's called Coursera, so you may have heard of it already. If you have not, I've put the link here, so I would highly recommend you check it out. So for example, in preparation of this talk, I looked how much courses are offered regarding climate change, and just on this platform, just by typing in climate change, could find 82 courses on climate change. So as you can see, they're also quite diverse. So we have, for example, from climate science to action, even kind of specific ones, climate and climate change in New Jersey. But also a bit more looking into the technical aspects, global warming, the science and modeling of climate change. So I would invite you to go there, explore the courses yourself, and have a look around. And another thing, which is, I think, really great, is that there are not only these courses, but actually you can go there and you can do a master's degree or a bachelor's degree completely online. So they offer like a myriad of degrees that you can do. So for example, looking here at public health, so you can see there's like a full online master's degree from Imperial College that you can do for a fraction of the costs doing it face-to-face. And one big advantage, I was speaking yesterday to the delegation of Togo, kind of making advertisement, to think about also when designing courses, to think about doing this as an online course, because, for example, in low-income countries, if you take people, for example, if you want to train healthcare staff, if you take them out of service for 1 year for them to do a master's, you will lose these people for 1 year in the system, right? And also these people, they lose their income, and these degrees you can do while maintaining your job. And still you have this component of online exchange, of networking, and these are top institutions that you can see here, so you get high quality content still, while retaining the people in their job. So I think this is also a key aspect for low-income countries to consider. Potentially you could also follow a blended learning mode, so that you have people come in every 8-12 weeks for a weekend to kind of meet face-to-face and to strengthen this community of learners. But I think in that way MOOCs can also be a great enabler in that sense that we strengthen healthcare and the quality of education while at the same time keeping people in their jobs instead of taking them out of them. Looking at the degrees, just to give you a tour, because I had the impression also by speaking to some of you over the past few days that not many of you know these platforms. So just to give you an idea, so for example, looking at nursing, so they even offer nursing degrees completely online. So they offer, for example, a Master of Science in Nursing completely online. You just can do it online. Also healthcare degrees, so a master degree in nutritional science and public health, of course, but also looking a little bit more into dietary sciences and so on. And also into data science, because my degree is computational sciences, but currently, together with Till, who is not here, but we are actually doing this ourselves. So currently we are doing this master's degree in analytics at Shorter Tech to strengthen ourselves for using methods in artificial intelligence, which there is a great need coming up in global health because we are faced with new data sources at new speeds coming in, and how do we deal with this data? So currently we are taking this degree, and I only can highly recommend it. We are also doing it while we are doing our jobs. And there's another platform that I would recommend you check out, edX. Caroline Mohl yesterday was from edX, and she introduced this platform. So it's another one of the top platforms. Just to provide this number again, yesterday she told us 44 million people are registered on this platform. So you just can imagine the reach of putting an educational program on these platforms. Are you trying to make this collapse?
Yes. No, it's better readable now.
Okay.
We are in the dark.
All right. I thought it's a way of starting the weekend, maybe. Looking at edX, at climate change, so I even found 180 results of courses on edX. So you can see the vast educational materials that are already available to everyone in the world that you could potentially leverage, also in capacity strengthening programs, and you just can take them and see if they may fit already and just integrate them. Also I want to highlight this course because it's a course that Rainer also developed together with Harvard University. I also would invite you to go to edX and check this course out. The health effects of climate change. And just because to give a bit of context, so we were at Harvard X in Boston or in Cambridge, and this is the entrance actually of Harvard X. So it looks it's very hidden, and it becomes better when you go up. So Harvard X, this is where they film all the MOOCs from Harvard, and Rainer was also there. They have a very professional movie studio there, and this is Rainer recording one of the sessions. So you can see it's like highly professional. And they have a huge team that supports the production of these courses, also in terms of content, and I was also sitting somewhere in the room. This health effects of climate change is quite interdisciplinary. So you can see it covers a climate science mini course, also focuses on heat and air quality, infection, nutrition, migration, also a little bit on research methods, and responses to climate changes or climate change. And so there are a few case studies that you can read up on. So yeah, again, a welcome or an invitation for you to go and check out this course, which also comprises like the big names from Harvard faculty that provides this content. And looking at the MOOCs that we have done, so mainly Rainer was the big driver there. We have already also developed a couple of MOOCs for climate change and health, kind of translating the expertise that we have in our institute. Yeah, as I said, mainly driven by Rainer, translating his decade-long experience in this topic. So we have a MOOC on climate change and health for a general audience, which is like a 6 weeks course teaching about the basics, so for people who want to get started into climate change and health research. There's also another one which was specifically prepared for the COP21, so this is executive MOOC targeting policymakers, so people who don't have much time. So it's kind of an express course that digests the 6 weeks course into only 40 minutes of very focused material for people to prepare themselves for COP21 to kind of update themselves on this topic. Also this climate change and health MOOC, the 6 weeks course was also done in French. So this was shot in Burkina Faso. Some of the colleagues are here, Yusuf and Ali. This was shot in Burkina Faso, and it was completely done in French. So this is a bit of kind of Querschnitt, how do you say this? Cross-sectional cut through our portfolio, what we currently have on climate change and health MOOCs. This is just a screenshot of the MOOC that they have shot in the Nuna HDSS in French, just to give you a little bit of a visual taste. We also have continued this MOOC journey. So another MOOC that was led by Alina Herrmann, she's a physician also working at our institute, is looking at climate change and health and implications for patient care. So essentially the physicians in their private practices will also be faced treating outcomes of climate change and health in the population. And so this MOOC prepares physicians to be able to treat such health outcomes as well in their private practices. And this course also accredits CPD points, and it was actually commissioned through the Medical Association in Nordrhein. So even now the medical associations in Germany have discovered that MOOCs are a great tool for education and have this commissioned and actually paid money for us to do this MOOC. And a completely new MOOC that we are doing as part of the Climate Change and Health Research Unit, maybe you have heard about this during the past 2 days. If not, I'm sure Rainer is happy to provide an overview of our work. So this is a MOOC on research methods, so it's kind of an on the previous ones that we have done. So this introduces participants into common methods that are used for conducting climate change in health. And it's also a reflection of our research unit that we have in the, that is funded through DFG. So it's a great example also for translating the expertise of such a research unit into publicly available knowledge. Here you can see Manuela teaching on mixed methods. And also on the left-hand side you can see the contents of this MOOC. So we are focusing also on data resources and data collection to provide an understanding where do you actually get the data to conduct climate change and health research, because it's not so clear, because for climate you need over at least 10 years of weather data. And where do you get this reliably for the location that you want to look at? Where do you get population health data, particularly looking at in Africa? Where's the data currently coming from? So these are kind of questions that we tackle in Module 1. Module 2 focuses on data analysis methods, particularly the methods that we are using for in the research unit, and then of course also modeling, an important aspect of course for climate change and health. Also the MOOCs that we have offered, they were translated into many languages, as you can see here, a few examples, so to make them more accessible. Because the language, the spoken language in the MOOC is English, but to make it also accessible to many other countries that may not feel so comfortable in English, we had them translated, and for this we also leveraged kind of our expertise in our institute. So it was climate change and health students that were coming from short courses that actually translated these subtitles. And we did it with like an open source software, so you can do this also very cost efficient. Also for us, just to give you a little bit of a glimpse, so you've seen the studio from Harvard, and we went a little bit more Hollywood maybe. I wasn't able to come up with a better word, but I thought global health and Hollywood, so all it ended up yesterday evening was Hollywood. Maybe it, yeah. But in any case, so you can see this was shot in Kisumu, Kenya. So all we had as equipment was like a microphone, like not a very expensive one, a tripod, easy or like a very cheap lighting, and a green screen. And this was all our complete setup. And actually, if you look at the MOOC, so this is the outcome of this recording session. I think thanks to Nikias also, who's not here today, recovering from the preparation of the symposium. He was doing a tremendous job in cutting and also translating this into what I would say like a really high quality outcome. So just by having a bit of equipment, you can actually achieve already a very high quality MOOC, which also hopefully can be an inspiration for you, that you do not need this kind of Hollywood high quality equipment to do a high quality MOOC. So all you need is like a good smartphone, a tripod, a green screen, maybe for $100, and then off you go. Can be yeah, a very low-hanging fruit in that sense. We also did a bit of research looking at these MOOCs, particularly also in who actually logs in as students, who takes this MOOC. And we looked, for example, at this Francophone MOOC that was shot in Burkina Faso, and we actually found a quite surprising outcome, in the sense that we had a global population, but we also had a very strong population from West Africa, which was highly uncommon looking at other MOOC evaluations. So we had over 30% participants from low-income settings, which was a great success in that sense. And we think the success of reaching this population was that the MOOC was shot in Burkina Faso, and facilitators were Burkinabe, speaking in the language of these regions, so probably making it more accessible in that way instead of high-income countries producing content. It actually came from the country that it was intended for, so probably our assumption is that this is the main reason why we had such a huge success in also reaching low-income countries. We also conducted a bit of interviews, so to see how the MOOC knowledge is actually translated into real life. So for example, one aspect was building awareness. So one person said, I am African and climate change and its effects are realities that we live every day. I can better explain the incidence of respiratory and cardiovascular diseases related to it, so I can work on development projects building awareness for the population. So this was one person that we interviewed remotely. Another course participant said, in relation to capacity building and knowledge sharing, sharing knowledge and building capacity with health workers and other community stakeholders. And there were also actually teachers that took these MOOCs. So one said that I will be able to retransfer certain topics to my students. So you can see if only half of this is true, there is a lot going back to the communities and also to students in terms of knowledge, which is fantastic. Yeah. Our latest work, led by Jessica, so we did a systematic review looking into MOOCs for health education, so particularly understanding how can we use these MOOCs to strengthen health education in low and middle income countries. And we looked at what was already done, what is out there, and we found, we included over 90 MOOCs in total that were offered in low and middle income countries. And we found that most of them are basically used in South Africa and Asia and not so much in Africa still. So just to give you a little bit of a glimpse, and but if you are interested, you're of course welcome to catch up with our publications. I'm sure the slides will be shared later. So which also leads me to a citation from a publication from the Lancet Commission on Education of Health Professionals from Frank et al. That by looking at the outcomes of the systematic review, we found that African countries are still kind of not very active, unfortunately, in making use of these great resources. That the effect of electronic learning is likely to be revolutionary, although how precisely it will revamp professional education remains unknown. And this is still the case, but from our end at Heidelberg Institute of Global Health, we are pushing hard to also bring this resource into Africa, so this, that we also can translate these findings that we found into actual outcomes in, for example, healthcare education in Africa. So with this, I also would like to invite you to register for our latest new MOOC on research methods on climate change and health. I think there's flyers laying around. So this is also a new MOOC in that sense, because you get to play around with data sets. So we not only teach you theory, but we also give you real data sets from our research to actually practice the concepts that we teach. So with this I would like to say thank you very much for your attention, and yeah, please register.
Thank you, Sandra. And questions? Yes, I see one up there. The hill again. Huh? I should run. I need a runner. I'm a runner.
1 second.
Thank you. Hello. My name is Baraki Satyenvaza. I work as an advisor at GAZ, as a digital advisor, digital health advisor at GAZ for the advisor ministry, GAZ. For the last 6 to 7 years, I was working in Kenya and Ghana, Togo as a digital advisor. We work, we advise the ministries, we work in communities, and what I realized there is the cost of network, of access to network is really high. So just people have to be in a certain position to be able to serve online, to take online courses like this. And I realized that in Kenya, for example, Wikipedia went into an agreement, for example, with Safaricom, which is the biggest telecommunication provider in Kenya, and they made this content accessible for free for the community. And my question to you would be, what are the efforts at your, in this context for making this, the content available for the community? Because I was in December, I was 3 weeks in Burkina, originally from Burkina, and we had 1 week of complete shut, so there was no possibility for me to communicate with my family. And when we had, when the network was available, I realized a bandwidth, I had to pay a high amount of money to get access to internet, and then I was like, how do they do? Someone, a student, for example, at the university who was really a low income, is limited. So, what are the efforts at your, what do you think, what are the efforts, are you making efforts towards making this content available? And that's one question. The second one would be, is this, only online streaming courses, or is there a possibility to have them offline? Yeah.
Thank you. So, Sandra, did you get all that? Okay.
Yes. So basically, I think your second answer kind of or your second question kind of answers the first a little bit. In the sense that, yes, the contents are available offline. So what you can do is, the 2 MOOCs that I've showed you on this patient-focused climate change and health MOOC, as well as this new research methods MOOC, they are hosted on our own server, which runs OpenEdX. And OpenEdX allows you to install an app on your mobile device, so your smartphone or your tablet. Then you can go to the course and you can download modules. So for example, like in Burkina Faso, for example, if you're in Ouagadougou, maybe at a hotel or at an internet cafe, what you could do is purchase a little bit of internet credit for 1 hour or so and download the courses. I mean, of course, we could also look into, currently we don't have the capacity. I know that these initiatives are going on. I know, for example, that some African countries, they have also agreements with social media companies already. Astonishingly, social media is much more quicker than educational initiatives on this, that you can access Facebook in very remote areas for whatever reason, I don't know, but we should also push for this, of course, for educational content instead of just the social media companies kind of pushing forward and making their services accessible to people. Yeah, I mean, in that sense, we already came a long way because education, I mean, if you think of it like 20, 30 years ago, this was not possible at all. And at least now all you need is a little bit of money for mobile data to download these contents. It's also not that it's like 50 GB or so, it's like maybe 500 megabyte or so, so it's not too expensive because you can also choose the quality level of the video, for example. And there's also, if all things go down, there's also the transcripts, but of course this is not the intention of such multimedia contents. But yes, I think what I take from this is it's true, we should push more to work also together with mobile providers in the respective countries to kind of start negotiating with them and to make them aware and to also create this kind of giving back to the society in that way that they sponsor educational contents and make them accessible for free.
Okay, thank you. Other questions? Over there? Look. I guess that box has some advantage.
Hi, thanks. I'm Lisa from the Heidelberg Institute, and I have a question regarding accreditation of the courses, because I've never done one, but I'm not sure, are they all accredited or not, or especially if you do like a degree? And also, what's your experience with employers? Do they kind of accept these courses or classes or degrees or not? And also let intern a comment, because we as PhD students have to take like a lot of, or have to do like a study program, and I'm not sure if MOOCs are accepted for that, and if they're not, like why not? Because that would be a very good way to take classes. Thank you.
Yeah, so our MOOCs, so we are pushing for accreditation, so the one that focuses on the patients, it's officially accredited for physicians, so you get these official CPD points that you need to do every year. So you can do this online and you get like your official accreditation, it's all official. So for the patient-centered one, this is for the others. So for example, for the new one, we're also looking into integrating them as a blended learning addition to certain doctoral programs throughout Africa. Overall, I mean, many courses are not accredited that you can do online, but then again, as I've showed, you can do full bachelor and master degrees online. So these are like full degrees. You don't see any difference on the certificate that you get when you do it. So you just can basically, I really highly recommend you check it out, because there's so many degrees that are offered by top-level universities making available their expertise online, and you can just basically do it on your own time while you continue to work. So these are full master and bachelor degrees that you fully qualify for. For example, if you do a bachelor's degree, you can continue face-to-face at some other school, or if you do a master's degree, you could continue with your PhD, for example. So these are full credits. And yes, this is another topic, and it's a bit sad that Till is not here today. But it would be great if we would accredit these MOOCs that we already have, like on climate change and health, as part of the MEDIS program, for example, so that it would count as credit points, because we know who did what on the MOOC, like how you performed on your exercises, when you watched which videos, so we kind of have this full transparency of your journey through the course. So in that way we could feed this back also to this program, because I know the medical faculty likes to know. So yes, I'll also take this as a note similar to the recommendation on working together with the mobile data companies, that this would be really great to push forward on as well. So yes, thank you.
Thanks, Peter. Thanks, Rainer. And thanks for all of those who have compromised the mid-morning nutrition to come back early. And unfortunately, you've taken caffeine, which means you're going to have more difficulty sleeping. But normally, I try and make sure people have a good sleep during these sorts of presentations. Okay, so I'm going to talk a little bit about global health education in times of crises, because I think pandemics and climate change are the sorts of crises that, unfortunately, we're increasingly dealing with, not just occasionally, but the majority of the time. And I think that has a lot of implications for the way we think about education. So I'm going to talk a little bit about the evolving context of education, because I think we have to be a little bit more attentive to the fact that it is changing, and more of the same is not necessarily going to be terribly helpful. And then I'll just really talk about some starting points that we're initiating, Miguel, which are trying to respond to growing needs and demands in global health. And I say trying because I think we're early in this agenda, and I'd appreciate any advice and wisdom from those who are assembled here. So the evolving context. It's important that we go back in history. We heard about Virchow last night, and I think a crisis, a sanitary crisis in the 1800s around the laboring populations in the port cities of the United Kingdom led Sir Edwin Chadwick to, in his report on the sanitary condition of the laboring population of Great Britain, to make this recommendation on the need for a new type of health professional. I'll read it. It says, "For the general means necessary to prevent disease, it would be good economy to appoint a district medical officer independent of private practice, with the securities of special qualifications and responsibilities to initiate sanitary measures and reclaim the execution of the law." So this was really the template for what has become the staple human resource in virtually every public health system, which is a district medical officer of health. These training opportunities related to district medical officers of health and others involved in the health professions were codified through a set of reports that all appeared a little over a century ago, all coming out of the United States, all with philanthropic inputs on them, and covering the Flexner Report, medical education, the Welch-Rose Report that Peter referred to in terms of public health education, and less known, but perhaps just as important, the Goldmark Report on nursing and nursing education. And these were really attempts to bring standards to professional training in health and moved beyond a sense that any education institution could do whatever they wanted, and that they would adhere to a common standard which then informed regulation and accreditation. However, as we move forward a century, the Lancet said academic medicine must take more responsibility for global health. So the reforms in education of the early 1900s were really focused around national systems. And a century later, people started saying, actually, we need to be thinking about the global health system. And in that context of crisis, and the one that we've been living through, we've seen that the health workforce has been a limitation and a barrier in many respects, as much as it's been heroic in the context of COVID-19. And some of the challenges relate to the limited surge capacity that we've had, hospital care systems that are run on efficiency have troubles surging to manage disproportionate loads. Long-term care was a place where Canada basically got slaughtered. We had no serious health professionals capable of managing infection prevention control in those settings. And that's where we led the world in terms of proportion of deaths in long-term care. But we also saw huge challenges in the ability of public health cadres, systems of local public health that were supposed to expand testing were unable to. In Canada, the only way we would notify cases was by sending faxes from a local public health office to our national public health authority. Often the faxes only had the single identifier that an individual who was nameless, who had no age, and had no sex tested positive. That was the extent to which the forms were completed, which was supposed to be the basis of national tracking and monitoring. And then we saw huge challenges related to managing procurement and supply chains for things like masks, medical equipment, and of course vaccines, all of which we're seeing in other parts of the world at the same time, and led to recognition that how we managed our supply chains in Canada was actually contingent on global interdependence because so many markets were demanding the same commodities at the same time, and there were a fixed number of suppliers. In addition, unsafe working conditions, massive burnout, especially now. So a lot of the health professionals who've been on the front lines for now 28 months of emergency are feeling underappreciated and are starting to leave. And in some respects, we have a great resignation in the healthcare sector in Canada because Canada's got a great pension system and lots of people who've said, boy, I've been working way too hard in the last couple of years. I'm going to exit early. So rates of attrition from the health workforce are accelerated at the moment, and there's no commensurate increase in entrance. The supply side of the workforce doesn't respond in a way that understands overall need. The supply side in economics terms is very inelastic. It doesn't move quickly and respond to these shortages. Then finally, attitudinal issues. And this is where we saw scientists, particularly those in public health, where hubris outpaced humility. And I think this is really very concerning. So we saw the world divide on the science associated with COVID. We had the Great Barrington Declaration, which was a set of folks who said, we can divide the population, protect elderly, and let the epidemic rip in younger populations because they won't be affected, and that will get us to herd immunity quickly. And that will also avoid lockdowns. And they argued very strongly, like we heard some others yesterday raising the question, that the consequences of lockdown would be too great. The Great Barrington Declaration proponents were met with a John Snow memorandum published in The Lancet, which were a group of scientists who said, you've got it all wrong. This is in fact the truth on COVID. And this polarization, I think, was really a symptom of too much hubris and insufficient humility. Because if you ask anybody, honestly, whether they really have understood fully what's happening in this pandemic at any point in time, and they tell you that they do, then I would submit that they may be suffering from a DSM-4 psychiatric disorder known as a delusional disorder. Honesty suggests humility. We really have been figuring this out as we move forward. And so what we need is not herd mentality. We need to think about how different parts of the knowledge base that's being assembled at heroic speed can come together and enlighten best paths forward. So the brave new world of global health, the pandemic is not simply the only thing we're dealing with. As others have said, like Richard Horton, it's a syndemic, noting its links with chronic illness and systemic inequalities. And also Srinath Reddy, the master of liberation, who's here today, he said it's not just viruses that cross borders. Tobacco, unhealthy ultra-processed foods, and sugar-sweetened beverages are transnationally marketed maladies and aggressively advertised addictions. So this is the global health landscape, which is not limited to infectious threats, of course, climatic threats, but also a whole set of behavioral and consumption threats that we also have to be sensitive to. And on the right here, this is some work that Jorn Thompson has been involved in which they've looked at the brave new world of global health and how politics and power, climate change, tech innovations, and demographic changes are all challenging our solidarity and therefore taking us into a new era. So if you look at the context then that we're facing and we need to be responsive to in global health education, it's a big menu. We have pandemics, syndemics, and climate change. We have systemic inequalities. We have systems performance shortfalls everywhere. Everywhere I state that. So it's not just in low-income countries. It's in high-income countries. It's everywhere. And then we have health tech and digital futures, which is a combination of enormous opportunity, but also some threat. The emics and the omics, this explosion of AI and apps, the move to precision and personalized population health, mis- and dis-infodemics, and then a whole new era of ethics and regulatory process that I don't think we've really come to terms with. And when you look at these, it makes me think of a Canadian author, and as a Canadian, I try and promote Canadian content whenever I can, by the name of Thomas Homer Dixon. And he wrote a book 22 years ago called The Ingenuity Gap. And his basic observation was that humanity is creating problems more quickly than we can address them. And that's a pretty worrisome assessment. And what he was calling for, which is so important for us who are interested in thinking about education in global health, was to ramp up society's ability to solve problems more quickly. And so he was saying we need to close this ingenuity gap. And his primary example, because he had been chatting with a guy called Rainer Sauermeier, is that this was most manifested with respect to the ecologic climate change crisis that not enough people 22 years ago were really thinking about. And when he looked at the rate at which we were creating climate problems versus creating solutions to climate problems, he came up with this idea of the ingenuity gap. And so I think it was prescient, and I think it remains a very valid diagnosis today. And unfortunately, I don't think education systems have realized their role in leadership, in forging the solutions or the individuals that can lead in the development of solutions as we move forward. To make it a little bit more challenging, I recently read this book by Michael J. Sandel called The Tyranny of Merit: What's Become of the Common Good. And I think this is a very, very important book for anybody who considers themselves to be an academic and linked to universities to read. And the reason I think it's so important is because one of his basic hypotheses is that higher education is accentuating inequality. And he draws primarily from the United States, which is a good place to draw from if you want to look at inequality. But his assessment is not limited to education systems in the United States. Standardized tests, which provide admissions to students, track with wealth and privilege. And they are the primary merit-based criteria for entry. He talks about the need to reconfigure inequality, or not the need, but the reality that we're reconfiguring inequality to align with ability. And he identifies a big diploma divide and the emergence of a credentialed elite. And I think if one doesn't understand the extent to which academic elitism takes us away from what Richard Cash was mentioning earlier, the need to engage communities and make sure communities are the focus of our academic enterprise, that we're going to not only have a dangerous divide, we're going to find that those communities increasingly distrust academia. And when academia loses its status and its respect in society, politicians may decide that the marginal dollar related to education and research may be better spent elsewhere. And so I think this is a bit of a clarion call for those of us in academia to pay more attention, because I don't think our future is secured if we're really not going to address the elitist culture that, in fact, has come to define the academic world. So, with that, where do we begin? What's the way forward? That's why I say some starting points, because I think the agenda is big, and on this front, I would welcome all your suggestions, because these are just small steps, I think. First, I think it's really important, as others have said, Peter this morning talking about the PhD for practice, that we really begin to think about how we can nurture leadership much more systematically for health. And so this is a meeting we held just a couple of months ago. We had the two co-chairs of the Lancet Commission on Health Professionals for the New Century, Julio Frank and Lincoln Chen. And then we had a great set of panelists that included Srinath Reddy virtually in a recorded message. But that session really put on the table a number of the things that we need to begin to grapple with much more systematically in education if we're going to be nurturing leadership. So, it was really trying to build and ask in a rhetorical way whether or not the Lancet Commission from 2010 had responded credibly to the question or its mission statement, which was to transform education to strengthen health systems in an interdependent world. After 12 years, the question was, are we transforming education to strengthen health systems in an interdependent world? And I think if you look at one of the breakthrough observations in the Lancet in terms of its 3 levels of learning, informative being very technical, depth-based, formative being the values that drive inquiry and action, and transformative being the leadership agents, attributes, or the things that make you change agents. That on the transformative learning, education programs remain very, very weak in most institutions. It's often seen as soft stuff. It's often seen as sort of Nike approach to advertising. You just do it. And it discredits and overlooks the wide range of competencies that are needed to negotiate and navigate change when it comes to complex problems. So, the dimensions of new strategy, I think, can build on 2 of the key recommendations emerging from the Lancet Commission, that we need instructional and institutional reforms based on 21st century technological platforms. But in this, what happens in education is invariably we move to instructional reforms and we overlook the institutional changes that are necessary. So if we said, what is really the global public health agenda that we need to stretch and reach for globally? And said, in order to achieve a greater capacity to engineer solutions in various contexts globally, institutionally, we would probably say we need 10 times as many schools of population global health or public health than we have currently. We're not going to get there simply by changing the way Harvard works or McGill works or Heidelberg's Institute for Global Health works, even though it's high. I mean, it's very high. But, so we have to think institutionally. Where are we going to get all the faculty? How are we going to create the opportunities for training more people in labor markets that are tight? So these are really a set of institutional, bigger picture issues that I think we have to pay more attention to. In addition, though, we have to understand the market. And this is what students, prospective learners, those who are going to move through the academic programs, what do they want? And what are they thinking about? And when you talk to young people, they're very different, thank goodness, from old people like me. They're borderless, local and global citizens. They can't afford not to be. They are aware from day one that they're living on a small planet that has huge problems. They're boundaryless. They are agnostic when it comes to what disciplines might be called, or disciplinary turfism. They're much more interested in understanding methods and tools that they can use to address important problems. And they want real-world experiential learning. They do not just want to sit in lecture rooms like this and listen to boring people like me. They want to get out and be on the front lines, get their feet wet, their hands dirty, recognizing the value of tacit learning in addition to more formal learning. So we really need to get to GHS WOW, Global Health Schools Without Walls. So at McGill University, we have extended into the undergraduate realm. Not the first university to do this by any means. There are a number of universities that have undergraduate programs in population and global health. But we did make this a very deliberately designed effort, in part to respond to demand. We had one course in global health in the undergraduate curriculum at McGill, and it got sold out in about 60 seconds, 150 spots, gone. So we put it on again in the second term, 150 spots, gone in 61 seconds. So we had this huge unmet demand, and so we said, let's put together a program. So very deliberately designed around courses, core courses, thematic streams, 6 key competencies, which I'll go over in a second, community-based experiential learning, absolutely integrated into it, admissions criteria that go beyond the academic record, and then with an expectation that we're really creating globally minded agents of change. So these are the 6 key competencies that define the curriculum and which every student will be expected to achieve. And as you can see, they don't align very well with classic disciplines: positionality and partnerships, interdisciplinary problem solving, understanding the basis of systemic inequities, research literacy, ethical foundations and frameworks, and knowledge mobilization. So those are 6 competencies that our team that was putting this together thought should define the basic things that every student will emerge from this program with, recognizing that many of them will go on and do further training, as other graduates of undergraduate programs have done elsewhere. We are looking at our master's program, and I put this up. This is what the American Schools of Public Health core competencies are for their master's in public health. And when I look at this, I get a very uneasy feeling in my stomach. Because as an economist who really loves demography, I see biostats and epi being 40% of what constitutes the 5 pillars of MPH training. And I think, my goodness, why are they occupying independent space, number 1? And 2, why is there no recognition of any of the other quantitative sciences that are so critical and complementary to epi and biostats? But where is climate change in this? Where is crises and emergencies? Where is ethics? Values? It's not there. And so the provocative question I have there is, it's time for a rethink. And when I was in Bangladesh with Malabika and Elena and others, we engaged a number of schools of population global health to rethink this design of masters in public health training. And we came up with something called the Savar Statement. Savar is just outside of Dhaka in Bangladesh, and that's where the People's Health Movement was born. And there is a kernel, I won't go in today, about how we might rethink master's training, and if people are interested, I'd love to chat. But this is one of the reasons that we think we have to rethink MPH training, because we also have a very good bioethics group at McGill, and we're looking at the competencies that are required for contemporary ethical challenges. And these are amongst them. And if you look at the extent to which societies have appropriately trained ethics cadres to manage this set of issues, we're way undersupplied. And all the regulatory processes that require ethical engagement and considered views on new technologies and new apps, et cetera, are going to be constrained fundamentally because people don't have the appropriate training in these areas. There's lots of opportunity. The MOOCs were just mentioned earlier, but I think in the COVID era, when we shifted everything online, there was a great opportunity to draw on the global academy. And here we put on a course about what are we learning from COVID-19, and this was the faculty that we gauged, free of charge. We asked them to come and spend 15 minutes talking to students. And we got folks from all over the world, across all time zones. No one had to get on a plane, so it was eco-friendly. And students had an amazing real-time opportunity to interact with policymakers or people actively on the front lines. And so I think these are some of the opportunities emerging from COVID, which we should be thinking about. But we also have to be looking outside of health. And these are two very important leaders in global health. One is Mohammed Yunus of Grameen Bank, and the other is Sir Fazli Abid, founder of BRAC. And these two individuals, neither of whom ever had an MPH, neither of whom trained in public health, probably did more for public health than any of us sitting in this room. And so we can learn because they took an approach to problem solving, beginning with those with the greatest needs. And when it came to health, they were much more open-minded and entrepreneurial than those of us who are steeped in science and the orthodox of thinking that we know how to create change. So I do think there's a great opportunity for being more explicit in the way we think about cultivating and nurturing entrepreneurship in global health. The last thing, it's a real paradox that in public health and medicine, we always say everything needs to be evidence-based. But we so rarely hold evidence up to what we do in education. So it's really time for us to bring more evidence to bear on our educational endeavors. We're trying to develop a way of monitoring our educational performance at McGill. And I can tell you that it hasn't been easy even getting to this matrix for thinking about how well we're doing with respect to student diversity or community engaged learning or teaching capacity. But I think this is an area that if we're really serious about educational reform, we can't let ourselves off the hook and assume that good ideas are going to make the change we need unless we actually identify serious outcome and impact measures that will allow us to walk the talk on change. So with that, I'll stop with, I think Jorn Thompson earlier in the week raised one of his good buddies, Albert Einstein, but he said you can't solve a problem at the same level that it was created. You have to rise above it to the next level. So I hope you will help us rise to the next level with your comments. Thanks very much.
Great, thanks, Tim. That was a very stimulating presentation. I see one hand already. Let's take a few questions. I am aware of our time this morning, so for those of you who didn't yet have your lunch, I know you're going to be thinking about it.
Thank you very much, Tim. I'm Alistair Woodward from the University of Auckland. I would like to get your thoughts on the question of institutional reform. You made the point that it's not just instructional. In fact, we are generally become more comfortable about writing a new curriculum than thinking about the institutions in which we work and the barriers they provide. We're in the midst of quite a struggle to get curriculum reform in our university, and it's brought to light a number of structural problems that are to do with funding, that are to do with academic advancement, that are to do with quite deep questions about what constitutes science and excellence. And I'd be very interested in your thoughts about how we might be able to work together in the cross community to confront those challenges and think of possible ways forward.
Great. Well, thanks, Alistair, for pointing out the challenges that you're facing. Let me reassure you that you're not alone. In my Just a few quick thoughts on it. First, I think it's so important for anybody that's interested in educational change to recognize that there are a lot of structural impediments and barriers. And so you have to be brave enough to take those on and think creatively about how to do it. Otherwise, you can knock your head against a brick wall and feel defeated by the system. The second is we have to think about new ways of developing educational opportunity. And I'll just give one anecdote on that front. When I was in Bangladesh working with BRAC, we thought it would be good to create a community midwifery program. And so I went to the head of BRAC at the time, and I said, I said, well, we have this idea of creating a community midwifery program. It's going to be really interesting. It's going to be a hub and spoke model. We'll have faculty that are accessible, students trained in 7 hubs in their local communities. It's going to be really great. And after half an hour, he said, well, it sounds like a good idea. And I said, okay, well, what do I do next? Would you like a concept paper or proposal or business plan? And he said, no, just start. And I was shocked. I said, what do you mean just start? He said, do it. And I mentioned that because I think that if there are really important things that need to be done, sometimes it's better to start them and ask for forgiveness rather than asking for permission. Okay, so I think sometimes we put too much in front of us in terms of insurmountable plans and etc. And in fact, when we start moving and get some momentum behind some things, all of a sudden, people are saying, okay, it's not whether or not we should do this, it's how are we going to do it. So I think that that's the sort of leadership that I learned about from, and we should try and think about further.
Yeah, I think it's very much aligned, but how do we make it in this world where only publication and grants are counting? How can we stimulate students and make them dream? And I mean, I enter this job with a dream to help and to be also like activists in a way. And how do we balance that in our work?
So this is a great institutional issue, which are the incentives for faculty and what we're trying to manage. I think valuing education and education leadership has a lot of room to grow, and I think without it, we continue to fall into the trap of publish and perish as the primary criteria for academic advancement. So a lot of room for opportunity there. I don't have any quick ideas on how to fix the system other than I think your diagnosis is right.
Yeah, so I'm Shaiba from the Global Health Institute. So if I look at the map and see where all the great global health institutes are located, so it's heavily centered in the West, kinda, and all the problems that we have are in other places of the world. And in order for those people to access those great institutions, they need funding. And if I think, for example, about refugees and migrant health, are there, for example, like scholarships only like linked to refugees, or only looking for refugee students in order to make them the next public health leaders, for example? Another thing also is that when people get the education that they need, master's program from those countries, they are faced with blockage if they want to pursue to PhD because their academic career does not aspire to the standards of those universities. So how can we move about all those problems?
So first, thank you, because you're articulating what in economics we call latent demand. So there's tons of people and populations in the world that would love to have more public health leaders, but they have no institutional opportunities, locally, or opportunities to get the scholarships or the subsidies to allow them to go elsewhere, should they be lucky enough. So a couple of responses is one, we have to, and this is why I say we have to look at expanding the supply of institutions. There's no reason why we shouldn't have great schools of public health in Yemen, right? And we don't, right? Or that we only have one great school of public health in the country when we need 10. So I think we have to, if we're honest and we're serious about global health, we have to continue to advance and advocate for the expansion institutionally, and not just pretend that it's McGill's program that is going to be universally accessible. We will never be. Secondly, a couple of things on access. When I was in Bangladesh, we were very concerned that all the MPH students were coming from silver spoon environments in Dhaka. Right? They were kids of well-off middle class or upper class people living in the urban setting. So what we did is we approached the United States Agency for International Development and said we want to diversify the admissions to our MPH. And so they gave us some money so that we could actively recruit from the lesser well-off areas of Bangladesh. And so we developed a program to bring in people who were just as smart and able, but had not had the opportunity to either apply or know about our program. And so that was a lot harder to do than we anticipated, because we had to get language competencies up, we had to create a whole 6-month retraining or upgrading or boot camp so that people could function in the program, and then we had to support them when they were in the program. And I think we made some progress, but I think that that's just one of the ways of thinking about improving the diversity and opportunity for people where you absolutely need public health leaders in those areas. The system is not currently conducive to them gaining entry.
So hello everyone, this is the last session of today before we go to the panel discussion. So in view of time, we keep our discussion brief. We will look into lessons learned from teaching and capacity building in times of epidemics. My name is Anna Munz. I work at the teaching unit at the Global Health Institute together with Olaf, and my background is in education, in adult education. I'm involved in the master course coordinating, but also in our international teaching collaboration.
Yeah, thanks a lot and good morning. You will have realized that we opted to have a little bit of a talk rather than having a formal presentation. We had a lot of them anyway, didn't we? So we are going to lead into discussion from here, and hopefully that helps. We keep it short, as Anna said. My name is Olaf. I'm helping out in the teaching unit a little bit with a marvelous team of 15 people, where we are actually organizing all public health and global health teaching across the university with an awful lot of international collaboration projects. And that is sort of where we're looking out when we found our niche. Anna was asking me if I could simply present very briefly in the history of how we actually normally operate. And we normally operate very much face-to-face, but over the last, let's say, 6-7 years, we've been coming up with more and more online products, if I call it like that, online courses, not expecting to MOOCs. Sorry, Rainer, I know you wanted us to, but exactly right, but we are going there, obviously. But also, it is that in a lot of our teaching, we are at the university, of course, bound to how the university directs us to do teaching in the medical faculty, which is in history face-to-face. And on the other level, if we look at our very, how how can I call it, boutique master course that is now running for more than 30 years, that benefits an awful lot from the actual interaction from medium-level managers who are then sort of experience exchanging rather than being sort of taught. And that in a way is really difficult to replace in online teaching. So we gradually and sort of briefly moved into more and more online products on several levels. And they're actually getting more and more, how can I put it, success perhaps, if you want to use that word, or let's put it there, more participants, and they're stabilizing on different levels. And with that, perhaps that was more or less the history, because then there was something happening, and that was suddenly, rather, we had to close our shops in a way to all face-to-face sort of activities, and most of you will have had exactly the same effect, I suspect. So hopefully our experiences are what is going to stimulate the discussion of how we're going to continue from here with a positive side of what we learned over the last 2 years.
So let's look into what we actually faced when I think it was the Thursday we had to shut down everything in the middle of a course. I don't know if it was Aurelia's course, I think it was Mariela's course at the time. So what did we have to do, or what did we not want to do? We did not want to interrupt the teaching of our students. Because we have a 1 year very intensive course, so there was no time to think about a very good solution for everything. So we just, at that time, we completely went online. And I'm also looking into this direction because some of our former students sit there, so they experienced all of this. And at a later stage, as the situation developed, we went to a hybrid model. So some of our students, they were able to arrive and they sat in our class, and the other colleagues joined online. And that was sometimes a challenge, but we also managed this one. So a lot of students had challenges because of travel restrictions still in place, or also visa. So what we did is we had to find a very practical, easy solution for those scenarios, but we also had to ask our colleagues and our students to adapt to that new teaching and learning format. What we did was we looked into systems, we looked into tools we can use, and luckily also the university gave us the flexibility to use all of this. We could shift to online exams, online assignments. That was never the option before, but the regulations were more flexible at that time, and we also hope they will continue considering those options. So we did that, but on top of our courses and modules, we also tried to include our more informal events we usually do, to do those online as well. And continue also with our excursion. We have one excursion to Geneva, and we try to adapt to the setting. And yeah, all of the stuffing, I think they framed it as a garden talks, because everything was closed. Also WHO were closed, of course, all the UN organizations where our students usually go to, and we find also solutions for that. And with that knowledge from our master course teaching, we also use it for other courses, and as Olaf mentioned, we are doing a lot of other activities. So what we learned, we use it, for instance, to shift one of our summer schools online. We develop new online courses and use the knowledge from the master course teaching. But what is this knowledge? So I already want to start with our lessons learned. First of all, and I mentioned it already, we saw we need to use the resources and competencies we have. So you see here, for instance, Frederick and also Nikias, they were running around here in front, so they helped us a lot. Luckily, we had them to introduce all of those systems, and that was great. We also explored that there is an e-learning department at the medical faculty. They supported us. So it was really important to look at the first place, what do we have, and use those options.
And from my side, I thought one of the key elements at the beginning was that the necessity to shut down all the sort of educational activities, and we are heading towards a full-blown epidemic globally. We actually need education that people are able to work in sort of a particular field and need to support that ridiculously. We cannot stop. We need to find a way how to do that. And I always like to adhere to the best is the enemy of the good. Very often you need to find solutions that are actually not the best. You need to sort of try to find a solution that you can operationalize. And that is also something that you learn. The second element, I think, the challenge is always, we heard earlier on, change agents are needed. Here I would actually say you need to see as well that people are quite reluctant to change. You cannot it's not possible. And in a way, one needs to overcome and really drive the change towards what is necessary. Here to go completely online, try to follow up with all sorts of regulations the best that you can, that you actually go ahead and have still quality teaching in one way or another, with capacity building. And the funny thing is, once we overcame sort of the barriers of we need to do everything online, once we, luckily in Germany, we had very early already the opportunity to go back to face-to-face, then suddenly people saw the opportunity of online activities. Could be sleeping at home in front of the camera that is switched off, but hopefully it was more like sort of the convenience that you don't need to run around, etc., no international flying and all of that. And then suddenly we faced that change, going back to face-to-face was almost impossible, because suddenly we had this hybrid sort of situation that we needed to continue doing. And even in our team, we were then thinking, oh, we want to go back to face-to-face, and then we realized we can't, because people who wanted to work with us in different levels were then saying, no, please continue hybrid. I'm still suspecting there's lots of sleeping behind the scenes. And that is another element I actually really would like to mention, because in the medical faculty, for example, you mentioned rightly that we have the systems provided by the medical faculty. And there, of course, you have very big groups of people, and we all face that, I suspect, isn't it? So you actually had what is a traditional sort of lecture, as horrible as it is anyway, I think, personally. But, of course, you have 300 people, you can't see the cameras. And you actually realize when you switch the system off, that 50 people were staying behind, and the reason for it is they were not there at all, right? So in a way, I think we all face this fact that we needed to learn that our systems, particularly the ones I feel always that are provided for you, which don't really fit your necessities, that they are actually really tricky, I think. No? Whereas on the smaller scale, where we had them this bespoke systems, we sort of, we managed, isn't it? No?
Yes, and we also realized that for some courses we learned, of course, that a full day in Zoom is also not appropriate and not manageable for all the participating individuals. So we adapted to that for other courses, made it shorter. I mean, also Caroline Moore yesterday mentioned their attention span is going back because it's very short. So we adapted to that. We developed different synchronous, asynchronous teaching and learning elements. So that was, I think, also a huge lesson learned, and probably everyone in this room agrees. You learn it then in the process. And one more thing I wanted to mention is, of course, this was only possible with the commitment of everyone involved. So I'm looking again into the direction of our students. They started to also meet outside or in smaller groups. We still had, we tried to introduce those meetings, and I think also from the colleagues a big thank you, because they also needed to adapt here and commit to that shift of teaching and learning that time.
And to conclude, I just wanted to say that we realize that everything is possible, we just have to make it do in one way or another, we need to adapt everything. I think we're going to take out, actually, that we probably are going to run far more electronic elements everywhere, embedded where they're useful. Not good. I wouldn't be able, I don't know, and I know the educationalist, I'm just a simple public health person. I don't know if we can actually already standardize our experiences in saying where does it make sense to put in electronic element XYZ of the variables that they're using. I'm not so sure. But I think in our particular case it was we need to go electronic everywhere from one day to the next. And we are going to discover right now in the completely different teaching products that we're having in different ways where it makes sense to continue building in electronic elements and where we need to clearly insist of having our face-to-face experience embedded. Would that be more or less right?
Yes, so in the time of the pandemic, of course, the online teaching accelerated. I don't think that speed will continue like that. But of course, there will be more online elements, but I don't see it in like there is only online and there is only face-to-face teaching. I see it more in a more flexible way, and I think this is what also the future of education will be, that where it's where we can introduce elements or do it as a preparation, for instance, we can do it in online, and what are the elements that need to be in face-to-face, and I think we need to do this like together with all of the students, of the colleagues teaching, of the colleagues organizing, to find like a good way in that channel, I would say. And I think with that we can already close our session. Thank you very much, and we can continue with the panel discussion.
Thank you. Let's just, we have time for questions and discussion, but let's move to the panel. And Tim, can you come down? And Sandra, are you still here? We're a small enough group that we can really. Richard is still online. Richard, are you still there? Yes, he is.
Yes, I'm here.
I'd like to really encourage not just like questions to the panelists, but let's have some more interactive discussion. This has been a very interesting session. We've gone all the way from, although the end, like emergency response to unexpected situation, which we've all experienced, to new modes of education, to community-based engagement, to new degree programs, and then Tim has gotten us thinking about profound revolution in the whole enterprise. Nothing small there. Okay, Malvika, I'm going to start off with you. And I would like to encourage everyone, don't just ask questions, make statements. What are you thinking?
Thank you, Peter. So my question is to the panel, that I think one element that we often forget, and I think we don't discuss and we don't have any systematic approach to train the teachers how to teach. You can have excellent curriculum, but then it can be taught by a really bad teacher. So I was fortunate enough to to be trained by Richard Cash, I think one of the best teachers in the universe. Then I had the opportunity to learn from my colleagues' team, Annie Adams, another excellent teacher, and I taught it learning by doing. Learning by doing. So there is no systematic approach to train the capacity of the teacher how to teach, and there is a real resistance of particularly the professors and senior teachers to acknowledge that they are bad teacher. But I'm sorry, I forgot also Peter. I also had the opportunity to co-teach with Peter, another great teacher. So not everybody had this opportunity. I was privileged and lucky enough. So I just want to have a question to the panel, that you can have excellent curriculum, all this discussion, everything will go to the water if you don't have a good teacher. And how can we systematically approach a teacher's training program and invest on that, and also motivate the so-called arrogant research-oriented faculty that they can be the best researcher but not a very good teacher.
Thank you. So, does anybody on the panel want to respond? that while I look for others who are, okay. Yeah. Tim, you can pass that microphone around.
Sorry. So, just to say, Malabika, Abigail, there were a lot of resources, online resources, and different opportunities for faculty to learn, the latest technologies of polling and how to effectively use breakout groups, etc. So there's a lot of really great resource material, which is now available in universities, across. But yeah, so this is available, and I think faculty should be encouraged to use it. The problem is they don't always do that, and I think that's where you have to start to I think change a little bit the criteria of evaluation of faculty. It's not just the students and evaluation that matters, but it's how faculty are using the pedagogy, the extent to which that is actually sort of assessed. And the extent to which they're making efforts to learn new pedagogic methods and that sort of thing needs to really, I think, be valued in terms of faculty assessment, not just the research enterprise, the number of grants you get, the papers you write in the best peer-reviewed, high-impact journals, but it's also demonstrated sort of capacity to really seek to be better communicators, better sort of teachers. It needs to be done.
It's a science and art.
Okay, we've drawn Professor Reddy now down to the lower level in the auditorium because he has something to say, so I'm going to pass it on.
And just to respond to Manvika, from the PHFI's own experience currently and hopefully further developing as well. We have had this problem between research and teaching reflected in our promotional pathways, because traditionally people who have come in from hardcore academia always look at research productivity as one of the key criteria for promotion. But we have over time actually developed 3 streams: predominantly research, predominantly teaching, and predominantly public health practice. We do not necessarily treat this as siloed streams. They are very porous. People who do research do teach, similarly vice versa. And we expect as many people to engage with policy and practice as possible. However, they have to state which is their prime area of focus, and their promotional pathways will be determined on the basis of that, with some additional lesser weightage for other components. So that way, it does give an opportunity for people to really develop to their full potential in their preferred area of work, which is still extremely relevant, not only for training public health professionals, but also for making useful contributions to the wider society. And it is possible again to transfer from one stream to another stream during the career path if they feel that their interests have changed or their potential can be further enhanced by moving to the other stream. I think that ability to navigate across the 3 streams is critical in any academic institution of public health, which seriously intends to make a difference to the wider health system. The second question, of course, I have for the panel is, while we are focusing on innovations in public health education to make them much more problem-solving, barrier-busting, and impact-enhancing type of programs, we are still mostly confined to people within the broader public health community. But given the fact that many determinants of health lie outside in other sectors, how are we, and they do not have the luxury of time to have long, formal training programs in public health, how are we going to engage with them to infiltrate, if you like, their own academic programs, their own training programs, their practical orientation programs, to influence their thinking so that they become much more sensitive and aligned to public health concerns, whichever sector they are in.
Okay, thank you. Let's take a moment to get a response from any of the panelists. While I encourage the backbenchers and the right wing, from where I'm standing, but also the left wing, to also think about some comments to make. Anyone on the panel? No? Okay. You got any action here from the right wing over here?
What about the middle bit?
The middle benches. Anyone? Right, let's get the panel towards you. Any on the panel?
Yeah, I think a very brief comment for me. First of all, on the issue of teaching, first, I think some more explicit standards and evaluation criteria, peer review, things like that, where it's not so much a black box and not purely a popularity contest based on how well your students rate you. So I think looking a little bit more systematically at feedback would be helpful. Second is, I went to medical school where we taught by people, the rule was you could not be taught by an expert in the unit that you were learning. So if you're doing cardiology, you could not be taught by cardiologists.
But
The issue is that every cardiologist, every biostatistician who trains an MPH student thinks that they're going to be biostatisticians like that. And they lose sight of the concepts that are critical and think that every student, if they can't mathematically write out the equations for a paired t-test, that they're incompetent. Whereas every student today is never going to write out the mathematical equation for a t-test, or whatever it is, I don't know what it is, but for the statistical equation, they're going to use the software. And what's more important is the understanding of communication. So I think the issue of delinking expertise in an area from teaching is also another way of thinking about it. The last thing I'd say on that is we should recognize, and I think a lot of you said this earlier, so much learning takes place by providing students the opportunity to interact amongst themselves. And so making sure there's enough time in the course of the curriculum to avoid too much didactic and provide that interchange, I think that's undervalued in terms of learning, and in some respects, I think it's important for teachers to be aware that they're not the sole source of knowledge for their students. So those are just a few thoughts on that great question. And Srinath, your point about how to infiltrate or how to engage other sectors to be more health-philic and purposeful. I just think it's a great suggestion. We should be thinking about that more actively.
And I just wanted to add, for example, also looking at new technologies. There are new modes of teaching coming in that can also maybe facilitate this quality of training, like thinking about flipped classroom models where you incorporate these high-level or high-quality materials that are available from like leaders of the field for students to learn, and then they come together in face-to-face sessions to discuss amongst each other and to clarify questions that they encountered while going through the material online. So yeah, when I first discussed with another professor here at IBR, and we told him about this MOOC concept, and he was also, wow, this is great, now I don't have to teach the students anymore, I just supervise them with their master thesis, and the students can learn from like the leaders of the field. So thinking in these times also there's new modes coming in, kind of maybe mitigating this challenge of bad teachers or teachers not accepting and that they are bad teachers, and continuing this journey. So yeah.
Great, thank you.
Yeah, I just wanted to add and also answer to Rabika's question. I can give you insights from Heidelberg University. So they also realized that challenge what you were mentioning, and they introduced a program for teachers, faculty, also our MT. Okay, so you did that, and so this is how Heidelberg will tackle this challenge.
But of course, there are two elements in it. You are in this course and you learn about all of the approaches, all of the principles, all of the techniques, but the other thing is to actually do it in class. And also to see what is not appropriate, but what is the need of your participants. And it can be, for one group, it can be that method, but for the other group, it can be another one. But I think it's only a learning process that everyone has to do.
Thanks, Anna. I just want to add also I think there is a growing recognition now in many universities that, first of all, there needs to be more attention to teaching quality and helping instructors become better teachers. And at UBC, I was quite impressed also that in the appointments and promotion process, a faculty member has to be observed in teaching in several hours of classroom instruction and a report written about their teaching quality as part of the promotions process, which is a good thing, but it's not easy to observe your colleague teaching and write them a bad report also. So, Rainer.
Yes, when I got interested in this climate change business, I realized that health is far behind forestry, agriculture in any. There were only 2 courses worldwide, and publications, we don't even mention that. So how can we, I ask myself, disseminate this north, south, east, west, and fast? And given the bureaucratic purpose to start formal teaching in any of our universities, it takes 2 years to set up a master course in Heidelberg. I came to this MOOC idea. It's not because I'm a MOOC fanatic, but that allows you to develop teaching products without the red tape of university approval. You can start without accreditation and do it in Africa. One contribution from an agricultural person, one from distributed teaching. It's distributed teaching. The research methods course in climate change, it's 2 African centers, Basel, Berlin, Karlsruhe, and it's so good. If you have a concept, you can call your expert in Canada or in Thailand and say, can you contribute? So you are fast, you reach north-south, you reach many people with new contents, ingenuity gap. We are too slow, we are running behind the problems. And if you have new challenges like climate change, pandemics, you name it, you showed it very nicely. I think you need to go that route, and the teaching institutions are just not able to react in the necessary multi-sectorality and access providing to people, particularly from the global south, and to low income. It's free of cost. So it solves about 80% of the problems that were mentioned today. I don't get any commission for advertising, but I think it's a very convincing tool. And you and I, Tim, we could develop a course, music in public health. I would play a little bit of piano and you would do something else. You would sing.
Okay, we've got a new word in the language, MOOC-fanati.
Yeah, I Standards got an idea of using, there is already existing like augmented reality and virtual reality for using this as a technology for remote teaching, because it can be it's very 3D, so once you get into that phase, I don't know if it out loud to people, but once you get into that phase, you can really actually experience as if it is real, something that is just created by the means of technology, and that could be very good for practical teaching in communities. But this technology has to go to really the people, it's not accessible. I think it's very expensive right now, but if this kind of technology is made accessible for teaching in the field of public health, I think it would be really great. I don't know, I would like to hear thoughts on this.
There's a scary prospect. We can get DeepMind, Google's DeepMind, to prepare a lecture on anything, and we can have a virtual avatar deliver it online in a completely dehumanized MOOC. Yes, Richard.
Just a few comments. One, I think the reason that case teaching is so good is because it's trying to solve a problem. It's not trying to put people into a box and say, you just talk about that. It's solving a problem. It's interesting that at Harvard, the best teaching is attributed to the School of Business School. Whether we agree with their message and so on, it's another issue. But the point of the realm of a business school is teaching. It's not scholarship. And they're constantly trying to solve problems. And I think the idea of solving a problem, flooding, what is it going to do? It's going to lead to agricultural problems and issues of healthcare delivery, and diarrhea, and so on, becomes the realm in which we develop a narrative. And that narrative is really, really important. And so I think that goes back to some of the comments that I was making, but trying to solve a problem creates a learning environment. It's not teaching, it's a learning environment in which we can try to solve the problem from many different perspectives. Thank you.
Thanks, Richard.
To the virtual reality.
Yes.
I just wanted to add, it's actually not that expensive, so you can get these virtual reality glasses for $200-300 US already, and there's even these cardboard ones where you just plug in your smartphone and you kind of create this 3D environment, and actually it's already being used in Africa, for example, for vocational training, and we are also currently piloting it in Zambia for anatomy training, because this is highly complex to learn from a book. So for certain topics, this totally makes sense to add, but not for everything. Yeah, it's definitely a great opportunity as well.
And very briefly only, since I tried for a little while, and I wanted to add to the problem-solving sort of question, because in my view, we actually heard in the afternoon about leadership programs. That's exactly what we're on about. I think so too. It's about collaborative leadership, right? Where we are actually really interested in order to get people on board who, with their practical experiences, can share those. Those people who are naturally working collaboratively, in my view, are the ones who actually get to these problem-solving activities, and they're the ones who then go ahead and integrate people, give time, as Tim said earlier on, in order to allow for experience exchange. I believe what we all did, training is necessary, but it's behavior change. It is not necessary, it's not sufficient to have training only to its participatory approaches. It comes with experience and collaboration, collaborative leadership style altogether, in my view. I think the element of integrating and assessing people, evaluating continuously for these sort of elements we just mentioned, is crucial in order to reach it. I really like this because we've been working, when I started here some years back, exactly on these participatory elements. And Malabika, you're a stellar performer in these particular ways, how to engage people. And this is what I think in Heidelberg really, and I don't know if Prof. Nisaf is still in the room from Tunisia, we've been running the WHO TDR Center courses already on participated training in many different places on the planet. And I think actually they are really worth doing, but it's not sufficient.
Wir haben fertig.
Over to you.
Michael?
Yeah, I wanted to take up Tim's comment that a lot of the health systems are now in crisis in terms of health personnel, post-COVID, and that there's a lack of supply. And I'm wondering, particularly with the growth of online teaching, if there's like a paradigm shift that could lower the cost of production so that we could massively increase supply. Because if you look at a place like the United Kingdom, they don't train enough health personnel, either doctors or nurses, to the point where they actually import doctors and nurses, from developing countries. And that's something that's not been readily able to solve, because the idea is that they really need to expand the number of medical students, and the Treasury doesn't want to expand because it's supposedly so expensive to train health professionals. So is there an opportunity now with this growth in the online teaching to decrease the cost and actually rapidly increase the supply?
Thanks, Michael. I think we're going to stand between you and your lunch. So we're going to bring this session to a close. I'd like to thank Richard Cash online, who stayed with us, and our panelists.
Yeah, I'm really going to close this speech.
Yeah, I won't even try to. Wonderful sketch. I became completely unprepared. I had never chaired a session before, and now masterfully did it. I won't even try to wrap up anything. I just think that this whole symposium, at least to me, was extremely inspiring. And I thank you all. And I must give you a bad news, the other group is already eating. So I think without much ado, we should just thank each other, congratulate each other, and have some lunch, and we can continue our talks outside. So have a safe trip home, and yeah, bye-bye, thank you, and
Thanks to the audio.
bye-bye, Richard.
Richard.